Before the availability of topical ruxolitinib cream, the 1.5% twice a day for atopic dermatitis in patients 12 years of age and older, we've had topical pimecrolimus, topical tacrolimus, both of which also carry black box warnings for lymphoma, and recognizing that these are a different mechanism. These are calcineurin inhibitors. The evaluation of those agents was different than the criteria that are used now. And even though they are effective, they appear to have a slower onset of effect. I don't think quite the magnitude of effect based on how they were studied and looking at what they did in clinical practice, in my practice, and also really not as much evaluation of itching, where topical ruxolitinib has a very rapid effect against itching. And then when we look at topical crisaborole, which is a PDE4 inhibitor, it's approved down to the age of 3 months, but there's a significant number of patients in clinical practice where it really is something that's difficult to use due to stinging and burning. So that happens in a fair number of patients, and they essentially cannot use the drug. And we don't see that irritation or the local skin reactions with topical ruxolitinib very often. So those are some differences if we compare them separately, not head-to-head studies, but looking at how they perform in clinical practice and what's in the data on those drugs.